Welcome to the RADECT Health Podcast. I'm your host, Yeshaya Koblik. Here with me is Dr. Safia Siddiqui. She's an MD, and she is operating in the state of Georgia, and she's also a engineer, having received her biomedical engineering degree from Georgia Tech. Welcome.
Thank you. Happy to be here.
So I wanted to kind of dive in and talk to you about what your journey is in a sense to innovate, because you both you've talked to me about wanting to apply your background in engineering to help the world of healthcare.
Yeah. So I didn't grow up in America. I grew up in Oman. It's kind of a developing country. So access to healthcare wasn't that great for me and my family. So I think I knew pretty early on that I wanted to go into medicine to make that difference and serve underserved communities. But I had a lot of friends and family members who were in medicine, and a lot of them expressed frustration with their careers and almost kind of told me not to go into medicine. When I was picking my major for college, I thought engineering would be awesome because I'd get to kind of blend that math and science part with the medicine. And I think that feeling that I had then was correct because I would say a few months into medical school, I really started to see what they were talking about burnout, about the priorities of medicine sometimes not being what you expect it to be. A lot of us, me and my friends that are all in medicine, we go into it with this idea that the patient comes first and are going to serve the community. But because of the structure of American healthcare and a lot of different parts that I'm sure we'll get into, it didn't turn out to be that way. So when I was wrapping up medical school and going into residency, I picked family medicine with the idea that it's very broad. Experience with newborns all the way to the elderly. And I thought I could give back to the community, but also kind of have this hybrid career where I can be involved with companies like RADECT that are trying to change how medicine is practiced. So that's where I'm at right now.
So when going through medical school, what were some of the things that you saw that kind of, as an engineer or having an engineering background, you'd say, oh, I would like to be done this way, but then it was done that way?
Yeah, and you know this, like in the engineering mindset is about efficiency and optimization and systems. Anyone who's interacted with healthcare, at least in the US, you've probably dealt with this as a consumer. We have Netflix now. It's so seamless that you can subscribe to it, but for some reason, and this is true for any other industry except for healthcare. I feel like even the process of scheduling an appointment all the way to when you show up to when the results are back and the follow up, it's just clunky. It's inefficient. Sometimes there's not as much empathy and focus in you as a person. But from the engineering perspective, I would just, clunky is kind of how I felt it was. Everybody has a different system. They don't talk to each other. Some are still using paper. Data is there. You have this whole repository of all this information in EMRs like Epic that we're not harvesting. We can look at that and predict what kinds of interventions are helping and what are not. So I would say like that lack of using data that's out there, the inefficiency, and just you would think that to deliver a good service, things would be grouped together in one center. Think about like a manufacturing center for electronics, for example. When you're manufacturing them, you try and you want to use the least amount of equipment because you're trying to produce a good product efficiently. But in healthcare, you have these little hospital systems that are all scattered from each other, and I feel like it's kind of the opposite of a systems approach, and it's not what I would call optimized.
So I guess I'll ask you this question, kind of put you on the spot. 15 years ago, I took an entrepreneurial strategy MBA course, and
Okay.
one of the assignments we were asked in class was, how would a computer look like in 15 years? And so I had this great response, which was we would have we'd fold out our displays, kind of like a you'd roll it up and fold it out. We would have ergonomic keyboards, which would adjust to us when we're typing. And basically, everything I wrote up, I got a good grade on it, but everything was wrong. The form factor of a laptop looks the same today as it does back then. However, we have smartphones today in our pocket, and people are developing augmented reality. Here, we're going to, in 15 years, we're going to see hopefully see a big change in the way it looks and the way it feels, as well as we'll see medicines improve, and we'll see hopefully a lot of improvement in just the way we do things. How would you like to see, as an innovator, what healthcare would look like in 15 years based on what you see as technology emerging and what you'd like to see as a doctor?
Yeah, that's a great question. And I think a lot of the implementation depends on political landscape, and topics that I won't go deep into today for the purpose of this podcast. But if your question is, in an ideal world, if I were to make some suggestions, I think we just kind of have to flip this breakdown of preventative primary care medicine and specialization. You would think, and kind of going back to this example of manufacturing, you would think that the preventative and the primary care would be the base. It would be the most number of providers and services, and then you would have specialists that are kind of at the top because they take more capital, they take more equipment, it takes more training, and primary care is where the vast majority of people should be. But it's kind of flipped. I feel like we clearly have a primary care shortage. We have more and more specialists doing more and more procedures, and a lot of them are not particularly necessary in the sense that they've been studied and their outcomes are not better compared to not doing those procedures. So I would say investing more in primary care. And when I say primary care, I do mean more preventative care. I mean not just medications, not just diagnostic imaging or labs. I mean true primary preventative care really is, and I think that's where we should be heading is lifestyle, diet, exercise. Genetics, I think, will be a big factor and should be a big factor. My physiology genetically is going to be very different than someone like you, but the guidelines are the same for both of us. We come from very different ethnic and familial backgrounds. So I think that more focus on preventing some of these conditions, because so much of what we deal with in the hospital today is preventable. So that's what I would like to see, more personalized. And I think that kind of comes along with the lifestyle as you build those that are, focused on diet, nutrition, non-traditional therapeutics that really should be traditional. And that kind of inherently becomes personalized because you can't create a program like that for everybody. So I feel like those are the big things. And some of the other things that I talked about was, less broken hospital systems, more consolidation, and more, which I think would lead to more efficiency as well, and more EMRs talking to each other, which kind of falls under consolidation too.
Right. So you've also been engaged with Y Combinator. They're one of the leading accelerators in Silicon Valley. And what was your experience like there, and how did that help you in learning a little bit more about your interest in healthcare and innovating within healthcare?
Yeah, this is a pretty crazy story because this was in the years running together. I want to say 2017 or 18, but the pre-pandemic world. But me and another one of my med school buddies, I knew her from Georgia Tech. She was also engineering going into medicine, very similar mindset. Her name's Kyle, but we would kind of sit together and do these brainstorming sessions about problems or inefficiencies that we saw during our medical rotations, and what can we do, what kind of product, what can we create to help either an inefficient problem or a device. And at that point, we were in medical school in Augusta, which is a hurricane center in the sense that we would get a lot of natural disasters. And we noticed that there wasn't really a process, there wasn't a system. Things were being collected on paper. So let's say there was a hurricane that hit and people would get displaced, they would be out of their medications, they would miss their doctor's appointments, and there wasn't really a system in place to handle that. And the downstream effects of that were immense, not to mention the cost of the mortality and the morbidity for those patients. So we had built a software then to kind of collect all these medical needs and to talk to the various hospitals and kind of help people in those kind of situations. And it was a Department of Public Health. That's who we partnered with for that. And that's how it ended up in Y Combinator. And the crazy story, the part is that we had a feature where we would do quarantine alerts. And this is pre-COVID. So thinking about that it still sometimes blows my mind because I think now it's very easy to say, oh yeah, of course we need more funding. Of course we need more technology in the public health department, but in a pre-pandemic world, no one really wanted to invest. It's very hard to fundraise. So Y Combinator was really great experience because what it helped us do is kind of take that baby idea and kind of really the kind of the basics stepping stones of the whole startup process is like market research, user feedback, how to create a good pitch deck, how to approach investors. All of those skills, that was me and Kyle's our first experience with the entrepreneurial world. So honing all of that, and it was a cohort of like-minded people. So the amount of like the feedback and the relationships that we would get, and our instructors were phenomenal. And sometimes the feedback was difficult, but I think it was one of the best learning experiences that I had because it really helped me hone all of those skills. And we were actually able to get funding in a very difficult, in a pre-pandemic world, difficult space to get funded. And I think I owe a lot of that to Y Combinator.
And what was the feedback you'd say that was difficult at sometimes? Was it just telling you that you had to make a strong pivot, or was it?
Yeah, our original, that's actually a really great question. Our original product was a device, and that was what we thought was the solution, and we pivoted to a software, which is, it's a completely different product. We had a core team that, we had to shuffle around, and that was very difficult because, people are involved in the beginning, they have different interests in navigating that ownership conversation, difficult feedback on pitch decks, where it'd be like, well, why are you saying that a certain way? Or, not just language, but how you stand, how you communicate, your body language. That can be sometimes difficult to hear because, it's you, and that's how, how to kind of hone those soft skills, how you communicate, how to approach investors, because, sometimes you have 60 seconds and my initial 60 seconds were not that great. So it took a few rounds of feedback to get to that pitch that, would grab their attention. So there's a lot of, little things and then a lot of big things too, like the pivot was probably the best example because, you think that you go into it thinking you have this product that solves the problem, and you have to hear that you're so wrong. That's not what the market is telling you. That's not what the user research feedback is telling you. So
it's always interesting. As with RADECT, we went completely against the grain because we said we want to work with populations that would be poor originally, and don't pay, and have health literacy issues, and say let's just tackle the hardest patients that we find, and then we'll work backwards. And sometimes I'm hoping that we would still fit into the healthcare system. Some of the things we're allowed to do. What is it like a doctor to be able to work through some of those issues, like trying to teach people how to be proactive in care? Are you able to do that? And if not, how would you like to be able to do that? Because that's something that we've gotten a lot of feedback from, that patients say, we don't even know where to start, or we just listen to the doctor and we wait till the next problem.
Yeah, I will give you like a, one sentence answer to that. We have to move away from fee for service. I think we just absolutely can't do the best for patients in my experience with that, because fundamentally as a physician, if my incentive, my financial incentive is to prescribe more or order more things or refer out, that just doesn't make sense to me. You're not being incentivized as a provider to do to for the patient to have better outcomes. You're incentivized to do more things regardless of whether the patient's doing better or not. And that was my biggest issue. I trained in a residency clinic where overwhelming majority, I would say over 80% were underserved. So, the time restriction, so having 15 minutes, like you said, I have to wait until the next appointment, that comes from the reimbursement insurance fee for service model. You have to bill a certain way, so you have 15 minutes, and trying to have somebody that is underserved that has transportation access issues, social determinants of health, a very difficult diagnosis. Trying to address all of that in 15 minutes is just not possible. And then I could spend that 15 minutes educating them. Let's say they have diabetes, I could spend that 15 minutes talking about carbohydrates and counting, which is the right thing to do, but I couldn't bill for it. And that's fine as a provider, but someone above me is on my back yelling at me about it at some point. I'm already expecting it, because I spent too much time. I did stuff that the hospital can't bill for, so it's like this constant struggle of wanting to do what's right for the patient, but this fear of, am I going to, have subpar statistics or lose my job because I'm not making enough revenue. So I really do think that that was my biggest challenge, is moving away from this fee for service model. It works great in other industries, but I think in healthcare, we need to start thinking about outcomes over interventions.
So you're saying that you could provide the medication management plan in those 15 minutes and review the medications, but if there's some gaps in that in everything else, then they'll be
Yes.
back seeing you, and you'll be trying to figure out what that issue is, and then if the medication is working or not, or if it's those other issues, and then it'll be a cycle,
Exactly.
and you're hoping the patient doesn't get frustrated that they stop seeing you.
Yeah. Exactly. I could use that 15 minutes, which is how long it takes to, let's say it's diabetes. I got to see where your sugar's at. So we're going to review that. Well, first of all, the whole vitals and intake, all that is 10 minutes almost. Even if you fastest nurse in the world, most experienced, you need at least 5 minutes to review all the medical conditions, any updates, vitals. That leaves me with 10 minutes, out of which 5 minutes is going in data review, right? Like, what are your sugars right now? What are you having any side effects? Are you having any reactions? And that leaves me with 5 minutes, 5 minutes to provide medical care. So, do I have to make a choice to talk about medications? Yes, I'm forced to, but at the same time, I'm not addressing so many things. Like, do you even have access to the medication? Are you able to transport yourself to the pharmacy? Is it affordable? What are the side effects? Yes, you're doing the medication, but what are we doing about, because you can have the best medication in the world. And diabetes is an example. I could be just keep going up on your insulin every time because you're just eating more carbs.
Mm-hmm.
But in that 5 minutes, I just don't have the time to address the carbs. So maybe you're just coming back to me and I just keep adjusting the insulin, and we're never having a conversation about the root cause. Is maybe maybe your breakdown of diet isn't great, or you're not exercising as much as you should be. And maybe the reason you're not exercising is because you have arthritis, but we never even got there because we had 5 minutes. You know what I mean? So I feel like we're stuck in this loop where I'm using those 5 minutes to just prescribe stuff and manage medications, which is necessary, right? I have to, because if I don't, those sugars are going to get really high and you're going to end up in the hospital. But what we're doing is stopgap solutions. So we're not addressing the core issue. All we're doing is like, okay, don't end up in the hospital, but we're not addressing what's going to actually help them get better long term.
So you're saying that qualitatively you could see where if that information was addressed, that would save a lot of additional appointments and a lot of time overall, but it
Yes.
hasn't been quantified. And it's difficult to quantify because it's dependent on every person. Everybody is different, so you would have to say
Exactly.
that person would take this much time, that person would take that much time, and it hasn't been quantified properly. So
Exactly. Yeah.
have you had the opportunity to work in value-based care, or is this something that's something you've just learned about?
I did actually work briefly in value-based care setting, and that's kind of where I think it solidified my decision that this is how it's supposed to be. Value-based care, and I think every state is different. The majority of the ones in Georgia, I think, are more like Medicare Advantage type plans. But obviously that's for a certain subset, and then you have to have Medicare Advantage, and it's not as large scale. We're missing a huge chunk of the population with the current value-based care. So conceptually, yes. I definitely, when I was there, I was like, this is how it's supposed to be. Obviously, there's a lot of fine tuning and logistics and scaling that has to be done, so it's more applicable to larger communities than just those specific subsets.
Where do you see were still the gaps within value-based care that needs to be addressed?
I would say the gaps in value-based care. There's not as much access to certain types of medications, so those are all. So I think it comes back to like the pharmaceutical and the political landscape, because a lot of the value-based care have, you're restricted to certain medications, and some of the newer, more I don't want to use the word better, but less side effects, or just kind of like more suitable for certain conditions, are really expensive. And when you're in a value-based care setting, you have let's say you have $1,000 to spend a month. If 900 of them are going towards this one medication, you don't have a lot left to play with. So even if everything else, you know what I mean? So I think the partnerships with pharmaceuticals for some of the more expensive drugs, I think is going to be a challenge, because it's a political and a pharmaceutical issue more so than the structure of the value-based care system. That was one of the biggest things. And then there are some concerns, I think, about scaling, right, with value-based care, for the reasons we talked about. And that's kind of why there's only a certain subset, mostly within the Medicare Advantage plan. When you start thinking about scaling that to every person in America, you start, because different people have different conditions. So how much would you say would be their allocated budget for that month? So kind of, I think when you start getting into the nitty gritty of it, for each individual person, kind of come up with a formula that works for everyone. When you start looking at the general population, I think it can get pretty tricky.
So, which begs another question. In value-based care as a doctor, how do you know how to allocate resources to things that are non-traditional in healthcare? Because, for instance, we've been having you talk to yoga instructors, which I'll talk about a little bit more. But do most doctors know, they could use these resources, and this is what's available to them to help these patients, and how they would help these patients, and then how they would work within a team-based environment? Or is that something that hasn't really been necessarily addressed in your education?
No, I think traditional medical education, and I've trained at academic facilities, there's not much formal instruction on physical therapy, or definitely not on yoga instructors. I think there's more awareness now, and I know curriculum is changing, but when I trained, there was no formal education in the classroom. So anything that I learned about, carbohydrates, or what kinds of strength training can you do for Right. Those kind of examples was on my own time, on my own research, or when you do your rotations, I will say you do work with, sometimes you work with this multidisciplinary teams. So if I do think that if we were to move, and we should, towards value-based care and more preventative medicine, education will need to change a little bit as well. So when you're training in medical school, again, everyone's different, but let's say you're doing primary care, you spend some time in cardiology, you spend some time in urology and all these specialists. But what would be really cool is if you spend time with a nutritionist and understanding the kind of advice and the kind of knowledge that you need. Same thing with physical therapy. So if you spent that time formally, just like you do with specialists, if you did that in your training, I think that would take a lot of that independent learning curve. Because once you hit practice, you're going to have to do all of that on your own time, and it takes a little bit of trial and error. So if you could do that formally in medical education, I think that would help a lot.
So, RADECT, we've put you in touch with several yoga instructors. So this was the first time you had to interact with them, and they've interacted with an MD discussing how both sides can work together. What are some of the things you got to learn about from yoga instructors that surprised you, or was something that was new, and how you saw them as a resource that you hadn't anticipated?
Gosh, I'm surprised all the time, and I feel like it almost feels like an untapped resource. I think on my call the other day, I literally said, "Where have you guys been this whole time?" And I meant it. I keep going back to these specific scenarios that I had in residency, or even I was working last week, and I keep thinking, man, if I had that resource back then, I'm surprised by just the breadth of the interventions. There's a targeted thing within yoga for things like constipation, anxiety. There are actual interventions designed specifically for each particular symptom or conditions, and the potential applicability of that to almost every disease is very surprising to me. I'm a little bit more familiar with Parkinson's because I have a family member that lives with me that has that, so I'll use that as an example. But Parkinson's is a neurological condition, but because of the way it works, you have a lot of symptoms just from the head down. You have anxiety, you have sleep issues. It's a very tough diagnosis, so there's a lot of coping and with the loss of independence. There's heart issues, there's gut, you get constipation, strength building. So just kind of going from top down, each one of those things I mentioned, there is something in yoga that is targeted towards that symptom, if that makes sense. So I was kind of surprised by how much there is that can help each individual symptom. And I just use Parkinson's as an example, but every condition that you can think of, there is something within yoga that can help a downstream effect of it. And also the medical knowledge. I think the yoga instructors, because of the clients that they work with, they're very familiar with the nuances of their clients and their patients. And it's not formal medical education, but it's almost better because it's practical medical education. I think you always learn more by doing, right, than by studying in a book, and they have a lot of that practical medical knowledge, which is awesome.
So coming back to that example of Parkinson's, we've had yoga instructors that have also been physical therapists, and they've talked to you about what they would do for a Parkinson's patient, and some of the things that were kind of new that you learned about that from a physical therapist or even yoga that would help Parkinson's patients that that would be part of kind of a curriculum they do, which would really help a doctor to know about.
Yeah, so and I think that's where a hybrid approach would be great. So Parkinson's is an interesting example because the first line of treatment is a medication that is giving you the neurotransmitter that you're missing, and it's Cinemet. And the way that the progress is graded is based on, let's say you come in, you have Parkinson's, and depending on your age and how severe it is, there's different medications that we can choose. But to simplify it, I'm going to just say, Parkinson's medication, and I give it to you. And we're just you come back for a follow up, and we're trying to decide if this is working. And when I say if this is working, how do I assess that? Again, you're in this 5-minute interview with a patient, right? Because we talked about the 15 minutes, and you realistically have 5, maybe 10. So when you're trying to assess that as a physician, you're trying to assess, are they taking it? Are there side effects? Is it working? And I think when you say, are there side effects and is it working? That's where the yoga instructors / physical therapists could really help, right? Because they're the ones that are spending time working with the day to day. So when I say that, so things with Parkinson's patients, like the gait becomes, there's rigidity, there's issues with walking and doing day to day things like eating or, going to the bathroom or dressing yourself. So what can I do as a physician in that 5 minutes that I see them in terms of assessing their progress? You could see how there's not much, right? I can observe them in the 5 minutes, but the yoga instructor and physical therapist, that when they're working with a graded program and they're measuring that progress and seeing them in their day to day and assessing their ability to do those activities, that information would be amazing because it could help me understand if the medication is working, is it not working, are there side effects? So that team-based approach of really leveraging their experience, their graded program, and their one-on-one time with the patient, and using it to make my medical decisions. I think it's invaluable.
So one of the things that always gets discussed with aging population is trying to find dementia earlier, because then or finding Parkinson's earlier, because then at least you can provide some programs. And a lot of people, they kind of fall through the cracks. It takes time to diagnose because you have to see longitudinally what is going on with the person. And
right.
It seems very difficult in the clinic to be able to do that because it's you don't have the time and access to these people that you wish you had.
Mm-hmm.
How would you see integrating that within normal healthcare between people that are non-traditional healthcare workers or people that will just generally know these people in a team-based environment, so that this becomes collaborative and part of the healthcare, and that information gets directed to you? How do you see the design of this?
Yeah, that's a great question. So I'm family medicine trained, and I love that because you really do get to know the family, right? And that's great because exactly like you said, it's a longitudinal thing. And as you get to know the family members and the patient, that takes so much time. You're in their 5th or 6th appointment before you can even kind of get an understanding of the dynamics and where they're at. A lot of the times I will talk to, it's the family members that will bring up the concern. It's, almost never the patient that's telling me, oh, I think I have dementia. It's the caretaker or the brother or the sister or the daughter or the granddaughter or, someone in the home that's saying, I'm kind of worried they're forgetting things a little bit more. They're, but that relationship building and that longitudinal relationship, you can see how that would be, 4, 5, 6 months in, maybe even a year. But when you're working with yoga instructors, physical therapists, and nutritionists, that information you would think would come a lot sooner because of that relationship building, because of the time that they're spending, and there's more one-on-one interaction with the patients. And, there's all these scales that we use in medicine, and they're all been validated by research studies, but I don't think they can be substituted for true experience, right? At the end of the day, family members are going to know more about, if you're living with someone and being around someone is I think you would trust that more than a scale on paper, right? Same concept. I think the more time you spend with them, the more relationship building that you have over that course of time with multiple members of the team, you're getting multiple perspectives. and they all have relationships with them that they're formulating. So when you come together as a team, the physician or the nurse practitioner, the PA with the physical therapist and the yoga instructors and nutritionists, you're getting a better, more whole picture of where that patient is, and the idea is you would understand that process of dementia earlier. And also, like, everyone's collecting different information. Like, the nutritionist is focusing more on brain healthy food or heart healthy food. And with that comes different things, like how is their access to food? What are their meal preps? So you're going to get some more information. Are they able to prepare their own meals? Versus from the physical therapist, you're going to get more of the, are they able to get around? Do they need help getting around? Who are they relying on? You see what I mean? So you're getting different parts of the story that will kind of make a big picture. And I think that will help early diagnosis, yes, but also better management, because you're targeting different, very important parts of that person's life.
So I'm going to go into a topic that's also even more complex, which is mental health for doctors. And
Yeah.
a lot of the symptomology for mental health, like autoimmune disorders, tends to be very generic, and so how are doctors coping with everyone? There's this expectation that as a primary care or internal medicine, you have to manage the mental health and know what to do. And how have you been trained that way? And what are some of the gaps, and what would you like to have for mental health? Because that's something that's constantly coming up, especially in underserved communities, because there's both a social and environmental issues, as well as social determinants of health issues.
Yeah, yeah.
And then you have the actual disorders that you have to look through. How is that? And if it's, and I guess I'll start there, and we can move on to a couple of little directions.
Yeah, access is a huge, I think, barrier. Just we talked about this earlier, but even with some of the better insurance plans, there's not an actual reasonable coverage for therapists. And that kind of takes you back to the fee for service, like things that are missed because there's no reimbursement model. And again, when you have that 5 minutes time, are you really going to understand where they are in their mental health? And then, as a provider, and you're taught to, you are formally trained, I think, really well, at least I think in family medicine and internal medicine, the primary care specialties, in motivational interviewing and how to get an understanding of what motivates them and things like that, and how to get, build rapport and, relationship. But I think time is such a limiting factor, because it's tough to get an understanding of that, where that patient is. And mental health is very, very tied to physical health. If someone isn't doing well mentally, their diabetes, Parkinson's, blood pressure is not going to do well either, likely. So in that 5 minutes, if you're trying to, bring the blood pressure down so that you don't end up in the hospital, there's not much time left to talk about the mental health part. So you say, okay, I'll refer them to a mental health therapist so that that person can kind of delve deeper. But then you get into these access issues. There's 6, 7 in the pandemic. I had patients, they just weren't able to get an appointment because everybody was busy, or there was it was not affordable, or in certain zip codes there's not a provider. There's just none. So I think it's just a combination of those factors that are leaving these huge gaps in mental health that are definitely negatively impacting just overall health of people too.
And what about the records from the mental health people to be able to tell you how well these people are doing, to adjust the if that's going to be a factor, and if you do know it's a factor, how do you cope with it as a primary care?
When you say records, you mean like notes, yes. Like charts?
No.
Yeah. Yeah. It depends. I think certain cities are doing better than others. In Atlanta, there's 3 or 4 major hospital systems, and 3 out of the 4 have the same medical record. So there is a decent amount of access between facilities. But yes, a lot of the independent or private or third party mental health facilities or therapists have their own system or paper records or their own software. And then, you play this game of, okay, we're going to get the medical records and then the patient has to send a release request. But then it's like a 2-3 week turnaround before they get in. And then someone has to like review them manually, which again is time, because who's going to review those records if you are able to obtain it? I can't tell you how many times it's just this back and forth, and I'm never able to actually get the records, or if I do get the records, it's just like a blob of text that it's tough to make sense of, and it's almost like too overwhelming and not helpful. So yes, that's definitely a problem. I think not just in that particular field, but in just any specialist care. It's very difficult to get records and do the back and forth and getting that data.
Cool. Well, I think it was an interesting conversation, and I think we through RADECT Health we brought you, Dr. Safia Siddiqui, on, and we thought we'd surprise you with yoga instructors and people that are non-traditional healthcare workers, and saying integrate into a traditional what a doctor does in some capacity. And that's what we're trying to integrate right now and make that more streamlined. For you, I come back to the question last before we end the podcast. What is from all the innovations you've seen in healthcare in the past 15 years, what has been the most positive for you?
I think I would say this focus on multidisciplinary preventative health, I think has been the push for it, especially in the last year, has been amazing. I think we do a great job with, heart attacks and strokes and things like that in the hospital. But when it comes to just preventative, comprehensive health care, we're dropping the ball here in America. So I think that really excited about that push in the healthcare industry and the health tech startup space. All these innovative solutions, RADECT, of course, being one of them, is this focus on how do we leverage diet, exercise, lifestyle, stress, anxiety, depression. How do we focus on all of those as a preventative healthcare delivery model, as opposed to just kind of being on the other end when everything's already, gotten to a point where you need procedures or hospitalization. So I think I'm most excited about that.
Cool. Well, it was great to have you, and thank you so much.
Thank you so much, Yashai. It's great being here.
Thanks.